Okay, pleasure to be here. I've never come to Norwich by train. Great station, isn't it? I love the Art Deco dome at the top. And the last time I was in Norwich was 1969. And this is new. I guess it's certainly this one. So it's nice to be back. Thanks for the invite to talk about this. So I thought what I'd do is sort of share with you some thoughts about addiction and how addiction poses a challenge in psychiatry, and particular challenges when addiction intersects with other disorders like schizophrenia and depression. So I'll give you my kind of take on this, and we'll have plenty of time for questions afterwards if you like. So the first thing to say that addiction is, at least depending on how you do the metrics, one of the top causes of disease in the Western world. It will be the leading cause of death in the world within the next 20 years, at the rate at which Africa and Asia are taking up drugs like tobacco and alcohol. So there you can see the WHO figures, tobacco smoking the leading cause of the burden of disease, and alcohol use there at the fifth of the table, and drug use about a quarter of that of alcohol use. So it's a huge problem. And it's a particular problem in young people. So alcohol is the leading burden of disease in men between the ages of 15 and 59 in the world. It's responsible for 4 million premature deaths, particularly in younger people. And this is the most chilling data. This is the data on mortality in Britain, the latest data we have. Alcohol is the leading cause of death in men between the ages of 16 and 44 in this country. And you might think that would actually be something we would take seriously. So it kills more people in road traffic accidents, suicide, or cancer. Interestingly, almost certainly this will be true for women by the end of this decade, because women are now drinking more than men. Which is one of the reasons why the government's guidelines last week brought men's drinking down to be comparable with women's, hoping, I think, that women will think they've always got to drink less than men. And here is a chilling statistic on how we have shown contempt for the harms of alcohol over the last 40 years. I'm particularly fond of this graph because it starts when I started, as I say, I came here to Norwich in 1969, my first year as a medical student in Cambridge. And they started collecting data then, systematic collection of data, looking at deaths from various disorders. So these are called standardized mortality statistics. These are the different disorders, these deaths from blood disorders, diabetes, endocrine disorders, liver disorders, the red one, respiratory cancer, etc. And they're all scaled to 100% in 1970. And these are deaths per 100,000 people. And what you see, and it's pretty obvious, that all the colours apart from the red one go down. And the reason this data is collected is to provide the health service with evidence about what it's doing, whether it's doing useful things. And you can see for all these disorders, we can take a lot of pride in what we've done here. Respiratory disorders have gone down, so the mortality rate is half of what it was 40 years ago. The same with cardiovascular disease. And some of the others have gone down as well. And that's what you'd expect. Society is getting healthier and medicine's getting better. So it's kind of weird, isn't it, that deaths from liver disease have gone in the opposite direction. Now you might think the first 10 years, well, that could just be within the randomness of the data. But by 20 years, you think the fact that liver deaths are now have gone up twofold and heart deaths have gone down by a third, you think there's probably something in this. Maybe we should do something to close this gap. Of course, what the government did then was just liberalise access to alcohol, so there was a massive increase in consumption and a lot further deaths. Now, 80% of these deaths are due to alcohol and 20% are due to viral hepatitis. And liver deaths will exceed heart deaths in terms of killing men, again, by the end of this decade. And most of that's due to alcohol. And the fact we've done nothing about it, it's an insult. It's an insult to me as a taxpayer, it's an insult to me as a doctor. And it's insult all the people who are dying from liver disease, because we know what causes it. We know cheap, easily available alcohol is the cause of that massive rise. And we know that countries that have had sensible approaches, like France, which have done exactly the opposite of what we've done, they've made alcohol more expensive and they stopped advertising it, have seen falls in deaths from alcohol, comparable with the falls in respiratory disease and heart disease in this country. And we all know that. And the fact we've done nothing tells us that our political system is completely corrupt, and it's corrupted by the drinks industry. About 70% of politicians take some kickback from the drinks industry every year. So that's just setting the scene a little bit. I want to talk more specifically about addiction now. And addiction's complex. Addiction falls into this center of this triangle between social factors. Clearly, I've shown some of the social factors. Cheap available alcohol makes more people addicted. But there are also drug factors. Drugs have different propensity to cause addiction. And there are also individual factors. Some people can drink all their life and not die, and others can die very quickly. And my particular research interest is along this axis, because brain mechanisms are important both in drug factors and in these personal biological factors. But addiction doesn't exist without all three coming into play. You can't, for instance, talk about an addictive drug based on its pharmacology. How many of you have ever taken heroin? Well, not many of you want to own up to that, but a few of you will. How many of you have taken loperamide for diarrhea? Lots of you. Well, in the test tube, loperamide is equivalent to heroin. Loperamide was made to be a painkiller like heroin. Interestingly, it doesn't get in the brain, or it does have to get in the brain, but it gets pumped out to the brain so fast you don't notice it. But in the test tube, they're identical. So the ability of the drug to get into the brain is pretty critical on whether it's addictive or not. So over the years, I've done a lot of research in this field. I've written a lot about it. If you want to read the sort of summary of what I'm saying, it's in this book, Drugs Without the Hot Air, which funds my charity, Drug Science, which is the only charity in the world, I think, that tells the truth about drugs. It doesn't have any funding from either the drinks industry, the drug industry, the pharmaceutical industry, or government. And this diagram here summarizes, I think, the key issues we have to think about when we are considering addiction. And the first thing to say is, obviously, it's complicated. There are very many variables. And different variables are relevant to different people. So some people take drugs for pleasure. But a lot of people take drugs to reduce suffering. Some people take drugs because it gives them meaning in their life. And the memory of drugs is often one of the most profound memories that any individual have. I can certainly remember the first time I vomited on alcohol. That was also in 1969 in Cambridge. And then there's a bridge. The use of drugs is multifactorial, but at some point, some people cross this bridge where they go from using to needing, and then you get into a whole series of different brain mechanisms such as impulsivity and compulsivity. The habitual use of drugs, many people use drugs even though they don't even like using them anymore, but they can't. They just can't stop using them. And then of course there's a whole issue of withdrawal, which drives continued drug use in order to avoid withdrawal. So it's complicated. And anyone tells you there is a single neuron or a neurotransmitter which underpins addiction, then they're being naive. And addiction is an individual experience to an individual patient. And there are fundamental differences. So here's an example. Some people would say, the greatest ever female painter, Frida Kahlo. And she was living with a great Mexican muralist called Rivera. He was having multiple affairs. She was unhappy with that. And she said, I tried to drown my sorrows in alcohol, but they learned to swim. And so she was taking alcohol, as many people do, to deal with grief and depression. And like many people who rely on alcohol for those purposes, she developed tolerance to it. And then, of course, the problems came back. And that is a hugely common. Half of all suicides are committed by people who are drunk at the time. Some of that's because they're alcoholic, and some of that's because they use alcohol to get the courage to kill themselves. Here's another example, but a different one. So here's Tatum O'Neill, the youngest ever Oscar winner, marries the greatest tennis player at the time. McEnroe has 2 kids, lives in this wonderful apartment in New York, and says, when she's coming out of her heroin addiction, the only time I felt whole was on heroin. So you can have everything, but you still have this lack of meaning in your life. And there's no question that for many people, drugs fill a gap that sometimes they didn't know they had, but often they did know they had, but they didn't know how to fill. When I worked in the USA looking after the research ward, of the alcohol research ward in the National Institute of Health in the States, I used to interview every patient who came in for our studies. And I remember one young man, he was, I think, 27, 28, and I asked him the question I always asked him, tell me about your first drink. And like most of them, he could remember his first drink. He said, I was 7. I've been out fishing all day with my dad. We're in the Midwest. And we came back to the truck. It's been a lovely day. It was very hot. And he gave me a cold beer. And I drank a can of cold beer. And then suddenly I felt right. For the first time in my life, I felt right. I realized then something would be missing. And from then on, I was an alcoholic. I just drank it every day to keep that rightness. Until, of course, in his early teens or late teens, he began to become severely dependent and then got into problems. So there is this phenomenon that the drug itself has a particular impact on the experience of self as a wholeness of meaning to many people. And if we ignore that, it's going to be very hard to stop people using drugs. Now, there's been tens of billions of pounds spent over the last 20 or 30 years researching drugs and why people take drugs, and the mechanisms by which drugs produce their effects. And we know quite a lot. But, in fact, we don't know very much, because everything we really know is on this one side. So pay attention. This is it. So we know that addictive drugs are usually pleasurable when first taken. I know Steve Bazira's talked to you earlier on today about the role of dopamine in terms of pleasure. That's not true of all drugs, of course. People who smoke, and I guess many of you are smokers, most smokers have to work to enjoy cigarettes because the body's natural aversion to being poisoned by burning plant material makes you cough and sputter and sometimes vomit when you start. But due to social pressures or peer pressures, you can overcome that and then become addicted. Alcohol is extremely aversive. None of you, I bet, ever drink neat alcohol. Even vodka is kind of flavored. But mostly we drink alcohol that has got many more flavors in. And the systematic sweetening of alcoholic drinks by the drinks industry, making breezes and things, is a very simple ploy, but a very effective ploy to encourage people to drink more alcohol when they're younger, because alcohol is actually dangerous. The pleasurable effects of drugs are determined by dose. Generally, the more you take, the more pleasure you get. By speed of brain entry, the faster it gets in the brain, the greater the effect. You can see the sort of symbolic fast entry of the syringe into the brain. Hypodermics injecting into veins are the fastest way of getting a drug into the brain. Also, of course, the most dangerous. Smoking is not far off. An injected drug will get into the brain within about 20 seconds. Smoked drug will get in within about 30 seconds. And then there is a little bit of evidence, but very limited at present, that the brain receptors on which drugs work, genetic variations of these can make people more or less vulnerable to addiction. And the paradox here is that nicotine, the only one we can be sure about is nicotine. And the paradox here is that people who are most sensitive to nicotine actually are least likely to be addicted to it. And that's because when they first use it, it's so horrible that they don't become addicted. So it's actually aversive. And then drug withdrawal, we know that's related to the duration of use, the dose of use, and also the speed at which the body clears the drug. And particularly, again, with nicotine, but to some extent with benzodiazepines, we know that paradoxically, again, the faster the body gets rid of the drug, the more addictive the drug is. So if you're one of those people who metabolizes nicotine fast, once you're dependent, it's much harder to stop because you have more severe withdrawal. So that's what we know. That's it, not much else. But we also know that reducing use reduces harm, and this is the basis of this government Public Health England recommendation this week to reduce alcohol consumption, because particularly for alcohol, and to some extent with other drugs, there is a non-linear relationship between consumption and harm, which means that even small reductions in use will produce very big and multiplied gains in health. So this graph shows the harms occurring to men in terms of the likelihood of dying from an alcohol-related illness in men in blue and women in purple. And the first thing you see is that women are less vulnerable to alcohol than men, which in itself is a paradox, because women have higher blood levels of alcohol than men for the same intake. But estrogens seem to protect against the damage from alcohol. And that's one of the reasons why the government has, or the Health England has decided to recommend the same drinking levels for women and men, because men are more sensitive to the harms of alcohol, even though they have lower levels. But men are more likely to come to harm because they don't have the estrogen protecting them, but also probably because they've got other problems like testosterone, which encourage activities which also lead to death when you're drunk. But the other, and the most important part about this, is the non-linearity. You have a lot greater harm if you're drinking a bottle of wine a day than if you're drinking half a bottle of wine a day. And you can see this curve here. If you're a heavy drinker, and a lot of you will be drinking a bottle of wine a day, reducing your consumption from a bottle to half a bottle, a 50% reduction in consumption will reduce the harms from alcohol by 8-fold. So that's something worth achieving. And even if you reduce consumption by 10% at this end, you have massive gains in health. And that's the argument for minimum pricing. We know that minimum pricing of alcohol will not affect the average drinker. Almost no person who pays tax drinks alcohol that's less than 50 pence per unit. So taxpayers won't be worse off, they'll actually be better off, because the health costs of the people who drink cheap alcohol will be attenuated. Because minimum pricing will reduce consumption on average of heavy drinkers by about 10%, from 100 to 90 grams a day. And that will give you a very significant, a 10% reduction in consumption will lead to about a 30% gain in health. So minimum pricing is an extremely effective and simple way of reducing the harms to users and reducing the cost to society. So minimum pricing of alcohol will save every taxpayer about £150 a year, rather than add any price to their drinking bills. So I want now to talk a little bit about different neurotransmitters. There's about 18 neurotransmitters in the brain. Steve has talked to you about dopamine, the pleasure neurotransmitter up here. But there are others. Endorphins may be involved in the ability of drugs to reduce suffering. Many people take opiates to deal with pain. Usually they're prescribed, but sometimes they're not. It's possible that 5-HT, serotonin, is involved in the meaning of drugs. The memory of drugs is laid down by GABA and glutamate systems. The wanting is probably dopaminergic. And also these impulsive and compulsive behaviors may well have a dopamine role. So we can dissect out different elements of addiction. And in theory, if we had tools, if we were going to go down the pharmacological route, if we had drugs which would target these receptors, these different systems, which in theory we have, but in practice we don't, we could individualize treatment of addiction in different people. So let's talk about stopping use. Let's talk about the reasons why people take drugs. Are those? Can we interfere with those processes to reduce the use of drugs? Well, this is all we know. This is everything that is known about how we can stop people using drugs, using a pharmacological medical approach. So we know that if you block the receptor for heroin with a drug like naltrexone, people will get no benefit from heroin because the heroin can't do what it does because it can't get to the receptor. So the problem is it's very difficult to persuade people to take that drug. The only way we've managed to persuade people to take naltrexone on a regular basis is by controlling their access to work. So we can make doctors, dentists, pharmacists take naltrexone every morning before they go to work, so we know that if they use heroin or fentanyl at work, it won't work. So we can, but that's the only group we can actually control the compliance of naltrexone. There is now depot forms of naltrexone and also implants coming along, which can potentially overcome that problem with compliance. Steve told you about dopamine being involved in pleasure and cocaine being a powerful releaser of dopamine. But in fact, dopamine drugs and dopamine antagonists don't work. So whatever dopamine is doing in addiction, it's not proving to be a very useful target for interventions. And we have vaccines. It's possible to produce vaccines for cocaine, nicotine, even in theory alcohol. But although they're under study, they haven't proved effective enough in humans at producing enough antibody titers to be really good. The principle is, of course, that if you're vaccinated against a drug, then when you take it, the body's immune system will just wipe it out, so it'll never get to the brain. But at present, we just don't have, the technology of vaccinology isn't good enough for this to actually be currently a viable treatment. So if we can't block the drugs getting to where they do their effect, can we actually block the effects of the drugs? So they get into the brain, what can we do? Well, one of the most interesting developments in recent years has been the realization that endorphins seem to have something to do with the actions of alcohol. And we can block the endorphin system using drugs like nalmefene and naltrexone. They're opiate antagonists. They block the effects of heroin, but they also attenuate some of the effects of alcohol, and I'll show you that later. We don't yet know how they work. We wonder whether they actually help people control their drinking rather than lose control under alcohol. And then, of course, the third approach is the traditional, although I suppose for some people it's still quite a radical approach, which is giving people a safer version of the drug they're addicted to. So you've all heard of methadone, some of you will have heard of buprenorphine, which are substitutes for heroin. And that gets people out of the vicious cycle of trying to raise money to take heroin. These are prescribed drugs. They can be used once a day with buprenorphine. You can even give it in high doses, and so it can be only necessary to take it 3 times a week. Sodium oxybate is a treatment which has been licensed in Italy and in Austria for a decade as an alternative treatment, a safer form of alcohol. And in France, baclofen is used extensively as an alternative to alcohol in some kind of substitution therapy. And varenicline champix is also a substitute therapy for tobacco. Now, I want to tell you that this is what I think these drugs do. Pfizer will tell you that varenicline is a treatment for tobacco, and it's a way of getting off tobacco. But most of you who've tried using Champix to get off tobacco find you're just addicted to Champix. And that's fine, because it's a hell of a lot safer than smoking. But it is a substitution, I think. It's not a cure in the sense that people would hope. Stephen has already talked about this. He's talked about dopamine and reward. And there's a famous cover of the Time magazine suggesting that it's the dopamine hook that gets us addicted. I'm not going to say any more about that, other than dopamine is a challenge, because dopamine is actually even more involved in schizophrenia, and probably in mania too. And so one of the great issues we have to deal with in psychiatry are people who have both psychosis and particularly stimulant addiction. You have 2 systems, two separate problems being mediated by the same dopamine system. And unfortunately, the obsession with dopamine in addiction has been very counterproductive to the development of treatments for schizophrenia and for bipolar disorder. And I'll explain why. So there's good evidence that dopamine is a mediator of psychosis and schizophrenia. And the main one is the bottom one. I won't go through, I'm not going to go through all of them. But this is the data I want to, this is the most interesting study. And it's interesting for a range of reasons. So this is a study which uses a technology called neuroimaging to measure the release of dopamine in the brain of people with schizophrenia and compare them with normal age and sex match controls. So this group here, the normal controls, were given amphetamine. I think they were given 30 milligrams of amphetamine. And then the amphetamine releases dopamine, and the scanning technique allows us to estimate how much dopamine is released in terms of occupation of dopamine receptors. And you see there's about a 10% occupation of receptors on average. Some people don't have very much at all, some people have quite a lot. But the patients with schizophrenia who are drug-free, they were coming into hospital for treatment of schizophrenia, they were given this study, they put in this study before they were treated. You see there's a much bigger range. And some people have a huge release of dopamine when they take amphetamine. And that, of course, is one of the problems with the use of stimulants, cocaine or amphetamines or crystal meth in people who have schizophrenia. It will release dopamine and exaggerate their symptoms. But there's a lot more in this study. Only some of the patients had increased dopamine. Half of them released the same amount of dopamine as normal controls. So now I'm giving you my interpretation of these data. I interpret these data as there's two forms of schizophrenia. Those who have more dopamine and those that have normal dopamine. These people respond to drugs which block dopamine, or dopamine receptors, typical drugs, haloperidol, risperidone. These people will respond to that. That's because that's the cause of their illness. Dopamine excess is the cause of their illness. These people won't. They'll just get side effects. It's even more interesting when you decode individual data. So here you see the change in psychotic symptoms. So people given amphetamine, some get more psychotic. These got more psychotic. Some of them got very psychotic. But some of them got less psychotic. And this one, so this is that axis, and this axis is how much dopamine is released. So this particular person here got a lot less psychotic despite a big increase in dopamine. So that person, I think, has dopamine deficient schizophrenia. He's improving when he's given amphetamine. Whereas these people are getting worse when they're given amphetamine. So to my mind, this tells us there are at least two kinds, maybe three kinds of schizophrenia. There are these people who get worse, these people who get better, and these people who don't change. No one in the world takes this into account when they are diagnosing or treating or researching schizophrenia. And I have been banging this drum for 10 years. I don't work in the field of schizophrenia. But to my mind, this is to try to treat schizophrenia as a single syndrome, when you know you've got, well, certainly three different groups, is absurd. And that's why we don't have innovation, and why so many of our patients fail to respond, because we're using the wrong drugs. This person, perhaps, should be given amphetamine. Now, any psychiatrists in the audience? So when did you last prescribe amphetamine to someone with psychosis? Probably never. Actually, I give this talk quite a lot. When I was in Sweden a few months ago, after the talk, two people came up to me and said, by the way, in the 1960s we did that. We gave people amphetamine, and some people with schizophrenia got better, and we kept them on it. But then we were told not to do that by the government, so we stopped doing it. And in this country, it's the same problem. Amphetamine's an illegal drug. And that's one of the reasons, I guess, people wouldn't prescribe amphetamine. In fact, almost every drug that works on the dopamine system is illegal now because of this fear of addiction. And the real sad point about that is that there's no evidence that making drugs illegal has ever had any impact on their illegal use or their recreational use. It just means that patients can't have access to them. And that is truly outrageous. And it's something we should champion and complain against. I want now to talk about the endorphin system. You all know about natural rewards from endorphins. And we've been very interested in the role of endorphins in relation to addiction and, to some extent, other psychiatric disorders. And we can do various things this imaging technology we have now allows us to look into the brain. We can count the number of receptors, and we can even now, for the first time, measure endorphin release. And we do it, we can look at these receptors. So these are a series of slices. When you do these scans now, you can measure at different levels. Usually we do sort of 32 different levels of the brain simultaneously. Here's about 12 on an old scan. And you can see the hot spots here. Hot means more receptors. So we stick into the body of the person a radioactive tracer. It gets into the brain, sits on the receptors, and the more receptors there are, the more radioactivity, the hotter the image. And this part of the brain here is called the thalamus, and that's probably where opiates work in part to deal with pain. And this part of the brain here is that part of the brain, is part of the pleasure circuit. And it may well be here that this is where opiates give you pleasure. But they also, there's quite a few binding sites in this part of the brain, which is called the cingulate cortex, and that's a decision-making part of the brain which integrates emotions and cognitive processes. Now, about a decade ago, we began to study this system. At the same time, a group in Berlin were doing the same studies. And this is their data, because it's more pretty than ours. And it looks at the density of these receptors in someone who's got alcohol dependence and who's been dried out for about 3 days, compared with a healthy control. And you see there's more binding in the alcoholic brain than the control brain. Now that is remarkable, because most people assume, because alcohol is so toxic to the brain and so damaging to the brain, that you would get less receptors. So if you get more receptors in the face of brain damage, that really does mean there's something interesting going on. Alcoholics have more of these receptors than normal controls. And intriguingly, the greater the receptors they have, the greater the number of receptors, the greater the craving for alcohol. So that was the first pointer to the endorphin system being involved in alcoholism and craving for it. The first pointer in humans. There was a lot of data from animal studies before that. We were doing similar studies. We've always tried to study alcoholics and heroin-dependent people in the same paradigms, the same protocols, because we're interested to know whether there are commonalities across addictions. And here you see, we found similar things. More receptors in the alcohol group, more receptors in the heroin-dependent group. So maybe there's a general feature that more of these receptors means more vulnerability to addiction. We also showed that, as the Germans did, the more receptors you have, the greater the craving scores. So we now know from our studies, we also know from studies in the States of cocaine, that there's a general feature. In drug withdrawal, there's more endorphin receptors. What does that mean? Well, it could mean two things. It could mean there's more receptors, or it could mean that the natural endorphin system, which binds to these receptors, is deficient. So that there's no competition for the tracer. When you give the tracer, there's nothing else stopping it get to the receptor. In order to resolve that question, we started to look at ways of releasing endorphins in the brain. And here's the first study, not of ours, but of a group in the States, showing that alcohol releases endorphins. What you see here is, this is the front of the brain, it's the back of the brain. You can see this particular part, the very frontal pole of the brain, there's reduced binding of the tracer after people have got a lot of alcohol. And that's consistent with alcohol releasing endorphins and the endorphins competing for the tracer, so there's less tracer binding here. So that's the first human proof that alcohol releases endorphins. We went down a different track. It's ethically impossible to give alcohol to alcoholics because you could cause them to relapse. So we've looked for other ways of releasing endorphins. And people, you know of things like runner's high. Well, you can't get people to run a marathon in a brain scanner. So we gave up on that. And sex was a bit difficult, so what we decided on was amphetamine. So we did the same experiment as the group with, I showed you the schizophrenia study. We gave people 30 milligrams of amphetamine in the brain scanner. And we showed that amphetamine released endorphins. These are areas of the brain where endorphin is released by amphetamine. These are the decision-making parts of the cortex, and here's some of the reward circuits. So this is the first demonstration that amphetamine releases endorphins. So now we have a probe. We have a way of studying endorphin system in the brain. And some of you may have seen in the news 2 weeks ago that we're using this technique. We showed that gamblers, people who've got gambling addiction, have a deficiency of endorphin release in the brain. And it may be that's why they gamble, because they're seeking a reward that isn't normally there. Their brain is reward deficient. So we've kind of come up with a new theory of addiction, which is not all-encompassing, but has some interesting predictions. So we take the view now that the most likely core to addiction is endorphin release. We know that alcohol releases endorphins. We've shown you that stimulants, probably through releasing dopamine, release endorphins. Heroin, of course, doesn't need to release endorphins. It just goes straight to the receptor. It hijacks the endorphin system. So, but all these addictions go to change the brain, either to give you pleasure or possibly to take away your ability to control what you're doing. These are two tenable explanations for why endorphins might mediate addiction to these drugs. And just by the way, I want to for those of you who are really interested in addiction, we think that actually dopamine is now protective against addiction. In fact, the release of dopamine by drugs like stimulants is necessary to stop you becoming addicted. But that's another story. The value of blocking the endorphin system in treating addiction is established. There are studies in gambling showing that it works. And here's the most recent study in alcoholism. So this uses this opiate antagonist called nalmefene, selincro, and it's taken when people are at risk of binging. So they take it, and usually people with this kind of alcohol problem are at risk of binging most days of the week when they start drinking. So usually they take it most days. And you can see that there's a significant reduction in the number of heavy drinking days. So here you see the people on placebo, due to being in a trial, there's a significant reduction in heavy drinking days. They reduced by about 6, but the people on the drug reduced by about 8 or so. And that effect continues over 6 months. So this is a persistent benefit of an opiate antagonist to help people control their drinking behavior. And this is a revolution. It's the first drug we've ever had that you can take while you're drinking and can help people control their drinking. And those of you who are alcoholics will know that being abstinent is really easy until your friends come along and say, let's go for a drink, or your friends open a bottle of wine. Because the social norm in this country is to drink. 87% of Brits drink. So saying no is very difficult. But using a drug like this so that you can actually drink without losing control could be, and is for many people, a much preferred alternative. We're not entirely sure how it works. We don't know whether it's through blocking the rewarding effects of alcohol or blocking the loss of control, and I'll show you how we're studying that now. But I want to finish by talking about the real problem, which is relapse prevention. As Mark Twain said, stopping smoking is easy. I do it every morning. Everyone can get off drugs. That's everyone. If you just lock people in a room, they'll come off drugs. The problem is how to keep them off. And this is what we have been trying to do. So we developed this thing called the ICANN platform. It's a collaboration between Imperial College, where I am, between Cambridge University and Manchester University. And we set out to try to develop a technology that we could use in people with addiction to study the brain mechanisms that underpin relapse, and then try to find drugs that would mediate those abnormalities. And I'm going to give you a couple of examples of why this is so important. So here's Amy. Now, I hope you've all seen the film. It is a truly, truly amazing film. Actually, I had no idea what a talent she was until I saw the film. But when she died, as her being brought out of her home, dead, I think I certainly, and I think most of us thought she'd taken at least drugs and maybe some alcohol, but we thought probably heroin or some other drug. When the coroners told us, although that wasn't front page news, the death was front page news, but when the coroner's report came out 2 months later, it was just alcohol. I was surprised. And then I realised from seeing the film that it was easier for her to crack heroin than to crack alcoholism. In fact, Bowie's even more interesting, isn't he? So Bowie was able to stop being a cocaine addict, but he couldn't stop being a smoker. But anyway, that's another story. She was apparently cured. She was, before she died, she had been in an abstinent treatment program. She met the criteria that the current government tells us are the acceptable target criteria for the treatment of addiction. She was clean, or in the case of alcohol, dry, for 6 weeks. But, like most people who stop using a drug, they lose tolerance. And like most people who stop using a drug, they relapse. We know from our own studies and many others, 90% of alcoholics who are abstinent will relapse at least once, and probably 95% of heroin addicts who are abstinent will relapse at least once. And when you relapse, you take the drug that you were using before, usually in the dose you were using before, but you give it to a brain which is no longer tolerant to the drug. And she died with a blood alcohol level of 450 milligrams per cent. Now that would kill me and would kill those of you who aren't heavy drinkers, but it wouldn't have killed her normally. She drank a litre of vodka in about an hour, and that killed her. The saddest thing of all is that we could use that fact to warn people about the dangers of alcohol. 3 young people a week in this country die like her. They die of acute alcohol poisoning through drinking more than they anticipated or wanted. But we haven't. We've just ignored it and brushed it under the table because we all like to drink and we don't want to be told and brought face to face with the potential harms. Here's another sad case. So here's Hoffman. Anyone who talks about recovery, the concept of recovery is an absurd concept. It's like saying you recovered from being born, So here he is, 23 years abstinent from heroin. None of us even knew he was a heroin addict at any point. Well, I didn't. I just thought he was a brilliant actor. And then he relapsed, and then he died. And there's loads of examples, So why is this? What causes him to relapse? Well, there are 3 factors. There are 3 main factors which predispose to relapse. One is stress. One is impulsivity. And one is alterations in reward systems, such as might occur when you're depressed or happy. And we set out to try to induce those effects in the brain and then look at the effects of drugs which would not be substitution therapy. We're not looking to find another methadone. Methadone or buprenorphine is extremely good. We want to find drugs which someone like Hoffman could use when he was beginning to feel the need to take the drug again. Drugs that would actually stop that need without making him addicted. So here's the study. It's the most complicated imaging study with drugs ever done in the history of the world. We took 3 drugs. We took naltrexone, we took a dopamine D3 antagonist to see if we could interfere with this process of liking drugs, and a substance K neurokinin antagonist, which is an anti-stress drug. These are research drugs, these are not on the market. And we took alcoholics, we took heroin addicts, we took cocaine addicts, and we took normal controls, all abstinent. And we put them in a scanner, and we looked at these systems, the sensitivity of the reward system, the impulsivity system, and the emotional system. And we also looked at how their brains were integrated. They're amazing. So these people had 5 different scans, at least a week apart. And we've got at least 20 in each group having 5 scans with drugs. It was a remarkably difficult study, but we've done it. What do we find? Well, I'm not going to spend a lot of time on this, but I just wanted to show you the principle. So here, this is what happens. When you put someone in a scanner and you give them a chance to win money by trying hard, they activate certain parts of the brain, particularly this part of the brain. Here, this is like a front-on view of the brain. And this part of the brain is a motivational system. And the more we know that, the larger the reward. We give them rewards ranging from 10 pence to £1. So they're sitting there in the scanner, and then it comes up to this reward, 10 pence, if you press the button fast enough. When it comes up £1, they press the button very fast. So there's money incentivizes people. That incentivization is driven in part by this dopamine system. So we can measure the brain mechanisms of motivation in an fMRI scanner. We can measure impulse control. The way we do that is they do something repetitively, and then they get a signal to stop. And they don't stop. And the signal to stop, the mechanism of stopping something, is very much controlled by these dorsolateral regions. Those regions I showed you earlier on, where endorphins are released under amphetamine. And then for stress, what we do here is we show them unpleasant pictures. There's a whole international series of emotional pictures. They're very unpleasant. I don't want to show them to you because people often find that they can't stop remembering them for days. They produce massive activation of the visual cortex because they're extraordinarily powerful images, but they also activate this region here. This is the amygdala. This is the stress center of the brain where both visual stressors or auditory or olfactory stressors lead to a stress response. So we've got it now. We can look at people's brains. We can look to see whether they have vulnerabilities in these different systems, and we can look to see what drugs do. And here's an example. So this is an intriguing finding. Why would narmethane stop people drinking? Why would it help them control how much they drink? Why would it stop someone who normally says, I'm going to have a pint, and then I'll just have another one, and then wakes up 6 hours later having drunk 12? How would it stop that loss of control? Is it that it stops alcohol being pleasurable? Oh, I've had 2, I don't want any more. Does it affect the control system? I can stop. In fact, so what we did here, this is a unique experiment. We took people and we got them drunk. We infused alcohol gave an intravenous drip of alcohol in a scanner. We got them drunk. And one day they're drunk on narmethane, one day they're drunk on placebo. And we looked to see which of the brain systems were changed by the antagonist. And it's this system here, it's the motivation system. So what we think now is that narmethane is a drug that reduces the tendency to get pleasure from alcohol. And that may be why people don't keep seeking to drink when they're on it, because they don't need the pleasure, or the pleasure isn't so good. So that's a first. That hasn't been published yet, but it shows you what we are aspiring to do. Unfortunately, as far as I know, we're pretty much the only group in Britain doing this, and there's only a few groups in the world. There's no research in the pharmaceutical industry whatsoever in this field. In fact, narmethane, the people selling they've stopped selling it in Britain, because despite NICE saying it was an extremely cost-effective treatment, doctors wouldn't prescribe it. And the reason for that is complicated, but it's partly that still a lot of doctors think that addiction is your own fault. That famous adage, what's an alcoholic? Someone who drinks more than their doctor. So even when we have drugs which work, we can't get them used in our country. So it's not surprising that there's no investment in this field, but this is vital, because we can get people off drugs, but we can't keep them off. So I'm going to finish now, because to give you time for questions. I've shown you, I hope, that addiction is complex, it's multifaceted, and it's enduring. And there are different elements, different behaviours, and different molecular mechanisms. And if we're going to treat people with addiction, we have to be aware of the subtleties, the differences between individuals. This idea that there's one drug fits all is ridiculous. And we've got to start doing things sensibly and in an individualized way. We've got a personalized treatment. And by that I mean personalized treatment according to the behavioral problems, not just personalizing it according to genetics. So I'll stop now. If you haven't bought the book, you should, because the book supports drug science, a charity that tells the truth about drugs. And I didn't bring any actually. No, I should have maybe. But anyway, if you buy it and bring it to me next time you see me on site. Thank you very much.